Today I will teach you something about a retinoscopy. Retinoscopy can be studied under the following headings. First, you should know the definition of retinoscopy. Next, you have to know the requirements that are necessary to do retinoscopy. Further, you should know the procedure of doing retinoscopy. You should have a knowledge of how the fundal globe moves in retinoscopy. Next, after identifying the fundal globe, you should be able to neutralize the fundal globe. After writing down the neutralization values for the fundal globe, you have to add -1 to the neutralization value. Next step is to objectively calculate the spectacle power. Next, of course, is to assess the subjective examination and find out what is the subjective correction of the patient's spectacle power. Then you have to learn about what is dry and wet refraction, and also about PMT, which is nothing but post-mydriatic test. You should have a knowledge of what is transposition. Next, you should know what is static and kinetic retinoscopy. After that, you should know how to verify whether the spectacle power which you have given is proper or not. And you must understand the difficulties which are there in retinoscopy. And you should know the other methods of calculating the refractive error of the eye. Coming to the definition, retinoscopy is defined as a method of examining the refractive status of the eye by the method of neutralization. This procedure is also known as shadow test or skioscopy. What are the requirements for retinoscopy? First thing that you should have is retinoscope for doing retinoscopy, and you should have a bulb by name Lister's bulb. Lister's bulb is a around 60 watts bulb which is painted with black paint except at one particular area which is having a diameter about 1.5 inches. Next, you have various types of retinoscopes which are used in conjunction with this Lister's bulb. Prissless with retinoscope contains plane mirror and a concave mirror. Next, you have what is known as streak retinoscope. Streak retinoscope does not need any source of light like what we need in the previous step, that if you are using prissless retinoscope, you need Lister's bulb as a source of light, but in streak retinoscope it is inbuilt. The source of light is inbuilt. Next, you have to have a Sneller's chart. When you ask the patient to look at a Sneller's chart, it is something like looking at a distant object. Patient should look at a distant object while you are doing retinoscopy, which is very important in calculating the proper spectacle power in a patient. This procedure is normally done in a dark room so as to accentuate the fundal glow which we see in this particular procedure. You have to have a set of trial frames. You have to have trial frame, and you have to have a set of trial lenses. Trial lenses will be in the form of plus and minus spherical and cylindrical lenses. Coming to the procedure, the examiner should sit in front of the patient at a distance of 1 meter, and the Lister's bulb is placed 25 centimeter behind the patient's head. Now, taking Lister's bulb as the source of light, you focus the retinoscopy light on the patient's pupillary area. Patient should essentially be looking at a distant object, and as the patient looks at a distant object, you can easily visualize the fundal glow in the midst of the pupil, and you are supposed to observe how this fundal glow moves. Movement can be of 3 types. Movement in the same direction as the movement of the retinoscope. Next possibility is no movement at all. third possibility, movement in the opposite direction. Movement should be checked both in the vertical axis and the horizontal axis. This is a diagrammatic representation of the distance at which the examiner should sit from the patient, and the patient is asked to look at a distant object, like in a dark room. Sneller's chart will be the distant object, and patient is asked to look at the Sneller's chart as and when you are doing retinoscopy. Now, when you observe the movements of the frontal globe, there can be movements in the same direction, no movement at all, or movements in the opposite direction. We will go to the first condition where there is movements of glow in the same direction. This kind of movement, that is movement in the same direction, is seen in case of hypermetropia, emmetropia and myopia of less than 1 diopter. For example, less than 1 diopter is minus 0.25, minus 0.5 and minus 0.75 diopters. When the movement of the glow is in the same direction, in such cases you are supposed to use plus lens or convex lenses for neutralizing the glow. Neutralization is to arrest the movement of the glow. If there is no movement of the glow, then it is a case of myopia of exactly 1 diopter. So here you need not do any kind of neutralization, as the glow by itself is already neutralized. It is not moving. Third thing is movements in the opposite direction is another possibility, and it is seen in myopia of more than minus 1 diopters. In these cases, minus lenses or concave lenses are used for neutralizing the glow. This is an example. For example, in the first case, on your left hand side, you see plus 3 on the vertical axis and plus 3 in the horizontal axis, which means that when you started observing the frontal glow, it started moving in the same direction as the movement of the retinoscope, and hence you started using plus lenses to neutralize it. You started neutralizing it with plus 1, but still it was moving. So you started neutralizing with plus 2. It is still moving, even though the extent of movement is decreased, but still there is movement in the same direction. So after that you have used plus 3 lenses so as to neutralize the vertical axis as well as the horizontal axis movement. Coming to the second example, which is there on your right hand side, in the vertical axis there was movement in the opposite direction. So you have used minus 1.5 lens for 5 diopters of power so as to arrest the movement in that particular axis. But in the horizontal axis, there was movement in the same direction, and hence you started using plus 1. Still the glow was moving, so you used plus 2 so as to arrest the movement of the glow in that particular meridian. So here the numbers along the principal axis indicate the sign and the number of lens used for neutralizing or stopping or arresting the movement of the glow. We will learn something about neutralization elaborately. Neutralization is a procedure of arresting the movement of the glow by using appropriate lenses. As mentioned earlier, if there is movement in the same direction, plus lenses are used to neutralize the movement, and the number of the lens used for neutralization is written along the axis. Conventionally, vertical axis is neutralized first. If there is movement in the opposite direction, minus lenses are used to neutralize the movement, and the number of the lens used for neutralization is obviously written along the axis. Sometimes the movement need not be along the principal axis. In all the cases, the movement can be oblique or bioblique. Next step is that you have to add minus 1 to the neutralization value in each axis. You are adding minus 1 because of the fact that retinoscopy is done at a distance of 1 meter, and sometimes you will be asked why 1 meter is selected for doing retinoscopy. The answer is that the distance of 1 meter is very convenient and it is easy for calculation when you do calculation of the spectacle power, and the glow is fairly visible. I am saying that the glow is fairly visible because glow will be better if you go to 0.75 meters, but at this distance it is fairly visible, but still you can make out the movements very easily. So it is better you do retinoscopy at a distance of 1 meter distance from the patient. This is an example of neutralization. In the first case, vertically there is movement in the same direction, so you have used +2 along the vertical axis, and the same value of lens is used in the horizontal axis so as to neutralize the movement. So now, before writing the prescription of the spectacle, you have to add -1 to the neutralization value. So after adding -1, it has become +1.0 and +1.0 in both the axes. So here +1.0 spherical will be the objective examination spectacle power, or spectacle power will be +1 diopters of spherical for this particular patient, which means that with +1 diopters of spherical, patient will be having a normal vision of 6/6. Many a times you will be asked in the Viva OC as to what are the reasons to do retinoscopy at 1 meter distance. So the distance is convenient, glow is fairly visible, and calculation of the power is much easier when you sit at a distance of 1 meter. These are the reasons as to why you do retinoscopy at a distance of 1 meter. Next step, as I told you, is the objective calculation. This is nothing but mathematically and clinically calculating the refractive status. As I told you earlier, to the neutralization value, you are going to add -1 and then calculate the power of the spectacle. So the description of objective correction will not be complete unless I give you a few examples. For example, in this case, in this particular patient, vertically there is movement in the same direction, so you have neutralized it with +4 lens, and in the horizontal axis also it is getting neutralized with +4. So you write down the neutralization value first, that is +4 vertically, +4 horizontally. To this you are adding -1 because the distance at which you did the refraction was at 1 meter. Once you add -1, the values become +3.0 and +3.0. So when you are objectively giving the correction, that is according to your calculation you are giving the correction, that is objective correction. Subjective verification is nothing but putting the same calculated valued lens in the trial frame and then asking the patient to subjectively observe whether the 6/6 is visible with this particular lens. So subjective verification is done later. Prior to that, we are doing objective correction and calculating how much power we are planning to give to the patient. So in this particular patient, we plan to give +3.0 diopters of spherical. Coming to example 2, in the vertical meridian, the movement was in the opposite direction, so you started neutralizing, and with -3 it got neutralized. In the horizontal axis also it was movement was in the opposite direction, so you started using -1 lens, it did not get neutralized, so with -2 it has got neutralized. To this you are going to add -1. When you add -1, it becomes -4 vertically and -3 horizontally. Unlike in the previous case, here the vertical meridian value and the horizontal meridian values are different. When the values are different, it means that the patient is having a combination of sphere and cylinder as a part of his spectacle correction. So hence the prescription becomes -3 diopters of spherical which is acting both along the vertical axis and the horizontal axis. But in the vertical axis, what we need is not -3, we need another -1 extra. So you have to put -1 diopters of cylinder along 180 degrees. When you put -1 diopter of cylinder along 180 degrees, it will start giving the effect along vertical axis. That is the reason why we are mentioning the axis at 180 degrees. Here you must remember that the cylinder always acts at right angles to its own axis. So the prescription becomes -3 diopters of spherical with -1 diopter of cylinder along 180 degrees. Example 3. So here there is, when we consider the vertical axis, the movement is in the same direction and it got neutralized with +1. But the movement in the horizontal axis was along the opposite direction, and hence we have used -2. So to this you add -1, then it becomes 0 in the vertical axis and -3 in the horizontal axis. Hence the prescription becomes 0 spherical, -3 diopters of cylinder along 90 degrees. Example 4. Here in the vertical axis, the movement of the fundal glow is in the opposite direction, while in the horizontal axis it is in the same direction. So respective lenses of -3 diopters helped us to neutralize the fundal glow in the vertical axis, and +2 along the horizontal axis helped us to neutralize the fundal glow. To this, when you add -1, it becomes -4 in the vertical axis and +1 along the horizontal axis. Hence the prescription becomes +1 diopters of spherical, and the same +1 diopters of spherical is acting along the vertical axis, but what we need is -4 there. To make it -4, we have to write -5 diopters of cylinder along 180 degrees. When you write cylinder along 180 degrees, it will start acting along 90 degrees. That is the reason why you are giving a cylinder at right angles. Normally, whenever you are choosing the spherical component of the spectacle, numerically whichever is lesser is considered for selecting it for spherical component. The higher one is later selected for cylindrical component. Example 5. Here the movement is not along the vertical, not along the principal axis. So it is along a different axis altogether. So -2 movement, it is -2, neutralization value is -2 along 30 degrees, while it is -4 along 120 degrees. Hence the prescription becomes -3 diopters of spherical. After adding -1, it becomes -3 and then -5, as you know very well. So the prescription becomes -3 diopters of spherical, and the same -3 is acting on all the meridians, and hence what we need in 120 degree, along the 120 degree axis is another -2, and hence we give -2 diopters of cylinder along 30 degrees. That is at right angles to 120 degrees. So the question arises here, and you will be asked what is oblique astigmatism and bioblique astigmatism. So in oblique astigmatism, you must remember that the axes of maximum diffusion and minimum diffusion are inclined to the principal axis, but they are at right angles to each other. In bioblique astigmatism, the axis the meridians of maximum diffusion and minimum diffusion are not only inclined to the principal axis, they are not at right angles to each other. That is the definition for oblique and bioblique astigmatism. You must remember that naming of the axis in retinoscopy or in ophthalmology is something like this. You can note down that 0 comes on this side, while 90 degrees is directed downwards and 180 degrees on your right hand side. Normally, the power of the spectacle whenever it is prescribed, the cylindrical component varies from 0 to 180 degrees. And you should not mention anything beyond that. 0 to 180 degrees, you have to remember, is the nomenclature that is given for axes that are used for cylindrical component of the spectacle prescription in ophthalmology. Subjective refraction, you have done an objective examination and you have calculated the power. Now you are occluding each eye and then testing the other eye by putting your objective calculated lens and to check whether subjectively patient is also accepting the same lens. Normally there will be slight variation of plus or minus 0.25 from the value which you have calculated, or many a times if your calculation is extremely good, then it matches exactly with your objective examination. So subjective examination and objective examination power, if they are the same, then it means that the retinoscopy done is almost perfect. Then let us learn something about what is dry and wet refraction. Dry refraction is when the refraction or the retinoscopy is done without application of mydriatic or cycloplegic drugs. Wet refraction is done by applying mydriatic or cycloplegic drug. Indications for wet refraction, you must know that when there are lenticular opacities, you cannot see the fundal glow properly, and hence you have to put a mydriatic so as to dilate the pupil so that you can visualize the fundal glow appreciably. In case of children, they start accommodating, they start looking at your retinoscope than towards the Sneller's chart, which is at a distant object. So in such cases, the values will be wrong. When they start accommodating, we have to apply cycloplegics to them and then do refraction. Application of cycloplegic will remove the accommodative power. In some very high powers also, you cannot see the glow properly. In such cases, it is better you dilate the pupil and then do retinoscopy. When the movement of the glow is not regular or appreciable, in such cases also, it is better you dilate the pupil when you are in doubt and then see the glow properly and try to neutralize it meticulously. You must know all these 5 agents that are used for wet refraction. Tropicamide, next is phenylephrine hydrochloride, cyclopentolate, homatropine and atropine. Out of these 5 eye drops, tropicamide and phenylephrine hydrochloride are only mydriatics and they don't cause cycloplegia. While cyclopentolate, homatropine and atropine, they cause cycloplegia, and you must know very well that cyclopentolate and homatropine cause partial cycloplegia while atropine causes total cycloplegia. So whenever you are applying various eye drops, the values that you are going to add will vary depending upon which eye drop you are using. So of course, in case of tropicamide and phenylephrine hydrochloride, they don't cause any cycloplegia, and hence you are going to add only for distance -1, and even in phenylephrine hydrochloride you are going to add -1 to the neutralization value. In cyclopentolate, it causes partial cycloplegia and you are going to add -1.5, in which -1 is for the distance, 0.5 is for the partial cycloplegic effect. In homatropine also you are going to add -1.50. That is again -1 is for distance and -0.5 is the partial cycloplegic effect that is caused by homatropine. When we come to atropine, then the addition will be -2. So -1 is for the distance, -2 is for the total cycloplegic effect that is caused by atropine. So what you did earlier is mydriatic test, that by applying mydriatic and cycloplegic you have done wet refraction or mydriatic test, and we are supposed to do what is known as post mydriatic test. On the day when we apply drops, we only do retinoscopy and send the patient and ask the patient to come on a particular day depending upon which eye drop you have used, and the day when you call the patient for further examination, that is known as post mydriatic test day. So for post mydriatic test, depending upon which drop you are going to use, you are going to call the patient for post mydriatic test after a few days. In case of tropicamide, post mydriatic test after 2 days is better, because it is presumed that maximum effect of tropicamide is for 2 days. Same is the story with the phenylephrine hydrochloride. But in cyclopentalate and homatropine, they act for about a week. So after 1 week, you normally call the patient for post mydriatic test. Atropine, as you know, causes total cycloplegia, and for the effect of cycloplegia to be reversed, it will take almost 1 month. So you have to call the patient for post mydriatic test after 1 month. And you must have a knowledge of what is transposition. Transposition is a method of writing the spectacle prescription in different form without changing its value. For example, +1 diopter spherical with +2 diopters of cylinder along 180 degrees can be transposed as +3 diopters of spherical with -2 diopters of cylinder along 90 degrees. So you must know the 3 rules of transposition. In the example which I have given, you kindly observe the transposed value and see the 3 rules. You will be able to correlate and understand what is transposition by correlating the steps of or the rules of transposition and this particular example. The first rule is that sum total of the sphere and cylinder will give us the spherical value of the new spectacle. Next step is to change the sign of the cylinder but retain the same number of the cylinder. Third rule, rotate the axis of the cylinder by 90 degrees. So there is what is called a simple transposition and toric transposition. What I have described here is only simple transposition, and that is enough for us to understand what is simple transposition. Now there are 2 terminologies. One is static retinoscopy and dynamic retinoscopy. Static retinoscopy refers to the procedure performed without active use of accommodation. This is normally done as we have described earlier, that patient should look at a distinct object and then by arresting the accommodation we normally check the power of the spectacle by doing retinoscopy. Dynamic retinoscopy implies when the procedure is performed with active use of accommodation by the patient. However, in the textbook it is mentioned that usefulness of performing dynamic retinoscopy has not yet been established in refraction. So for remembering the terminologies, you have to just remember static retinoscopy and dynamic retinoscopy, even though there is not much of significance as far as dynamic retinoscopy is concerned. So once you give a spectacle correction, you must know whether the spectacle correction given is proper or not. In this step, we verify whether the spectacle correction given is correct or not. There are 3 tests for verifying the cylindrical component of the prescription and 3 tests for the verifying the spherical component of the prescription. So what are the tests that are used for verification of the cylinder power? There is one test by name Stenopic slit test. Next one is Jackson's cross cylinder test, and the third one is astigmatic fan test. For spherical component, you have 3 tests. One is pinhole test, duochrome test, and fogging test. By doing these 3 tests for the cylindrical component and another 3 tests for the spherical component, you will be arriving at the most appropriate spectacle power for that particular patient. In all the cases, retinoscopy is not going to be very easy. In some cases, there will be some difficulties in doing retinoscopy. First such case will be when you have lot of opacities in the media in the form of corneal opacity or lenticular opacity, you cannot see the red reflex properly. When the patient starts accommodating, there also you will not only get wrong result, you will not be able to see the glow properly. There are some cases, as in case of regular astigmatism, scissor shadows are seen and they are slightly confusing. In irregular astigmatism, the movement of the glow will be totally erratic and then conflicting shadows will be seen. In keratoconus, we see what is known as triangular shadows, which are again confusing. In such cases, retinoscopy is slightly difficult than what we think. And you must know other methods of refraction, that is, other methods of calculating the refractive error of the eye will be, as you know very well, and most of the places it is practiced, that is autorefractometry, and another method is aberrometry. With this knowledge of retinoscopy, I think you will be able to answer all the practical questions that are going to be asked in retinoscopy and refraction in ophthalmology examinations. Thank you.